Good morning. This is your second half of your metabolism PowerPoint. Today we're going to be talking about diabetes. So your objectives for this lecture are to discuss the nursing management of the client with diabetes mellitus, describe common chronic complications of diabetes mellitus, differentiate between the symptoms of hypoglycemia and hyperglycemia, and to describe common chronic complications associated with diabetes mellitus. So diabetes is considered a metabolic disorder. It comes from a couple different things. So if you have what's considered type 1 diabetes, it is because you have an inadequate production of insulin. So your body does not make it. If you have type 2 diabetes, it is an inability of the body's cells to respond to insulin. So you do have some, you might not have enough, or your body does not respond appropriately to the insulin that you have. It is considered a metabolic disorder of the pancreas, so it interferes with the body's ability to metabolize carbohydrates, fat, and protein metabolism. Diabetes is considered a chronic disorder. Usually people with type 1 diabetes, it's not anything that they get rid of. They have to manage it throughout their life. Type 2 diabetes can be reversed with diet and exercise. So many people that have diabetes experience many debilitating and life-threatening complications because they leave it untreated and they don't take their medicine and they don't take steps to reverse it. So according to the American Diabetes Association, it estimated back in 2016 that there were 29.1 million Americans with diabetes, and of that 29.1 million, 8.1 were not even diagnosed yet. So those are huge numbers. So metabolic syndrome is a collection of manifestations that are said to predispose a person to developing diabetes mellitus. So if you have a patient that is that's obese and they carry a large amount of abdominal fat, if they have hypertension, so elevated blood pressure, if their lipids and their triglycerides are very elevated, so that's your cholesterol and your fats, if you have high blood glucose levels, and if you live a sedentary lifestyle. So all of these things increase a person's risk of developing diabetes. So prediabetes is before you actually develop diabetes. So people with prediabetes are overweight or they're obese. They have risk factors for diabetes, and they have one or more abnormal blood glucose level. One of the glucose levels that we can look at is called a HbA1c. The HbA1c looks at your hemoglobin over a course of 2 to 3 months. We usually use this number to determine in the primary care setting how well a patient is managing their blood glucose at home. If they have a fasting blood glucose or if they have an oral glucose tolerance or all three, it is said that they have prediabetes. We know a patient that has prediabetes it'll eventually develop into type 2 diabetes. It also can cause them to develop heart disease, peripheral artery disease, cardiovascular issues, stroke, heart attack. A patient that has an HbA1c of 5.7 to 6.4 is considered in that category of having prediabetes. If a patient has a fasting blood glucose between 100 to 125 after an overnight fast, that is indicative of prediabetes. So when we say a fasting blood glucose, this means that after midnight before their test, they are not having anything to eat at all. So they haven't had anything in their system. And we do a fasting blood glucose because after they eat, if they have carbohydrates and things like that, it's going to affect their blood glucose. So we want to do a fasting glucose to get a real accurate number. And we can also do an oral glucose tolerance test. If that comes back between a range of 140 to 199, then that is actually considered prediabetes as well. So we know that prediabetes, like I said earlier, is going to lead to diabetes, and that is going to lead to chronic health issues, which we're going to talk about in detail. Many people can delay or avoid type 2 diabetes if they participate in a weight loss program and they increase their physical activities. Even if they have type 2 diabetes, it can be reversible if they just watch their diet and increase their physical activity. All right, so we're going to talk a little bit about insulin because insulin plays a huge role in being able to manage our blood glucose. So insulin actually has three functions. The first function is that it's going to carry that glucose into our body's cells, and they're going to use it as energy. It's our preferred source of energy for the body. It also is going to promote the liver storage of glucose as glycogen. So when we don't have any left to use as energy, we'll go into our glycogen stores. And then third, it's going to inhibit the breakdown of glycogen back into glucose. When we see a patient that has type 1 diabetes, their islet cells or their endocrine portion of the pancreas does not produce insulin. So they don't make any insulin at all. Without the insulin in the body, the blood glucose levels are going to rise well beyond that normal expected range, and the body is going to start to break down fat and protein as alternative sources of energy. That process of breaking down fat is called lipolysis. When that happens, it's going to result in the accumulation of fatty acids and ketones. Throughout that process, ketones are going to start to accumulate in the blood, and clients are going to be prone to developing a form of metabolic acidosis known as ketoacidosis. We've talked a little bit about this in some of our lectures. So now we're going to talk about it much more in depth today. In type 1 diabetes, ketoacidosis will develop suddenly because of the total cessation of insulin production. So this is usually what brings our patients into the hospital. So type 1 diabetes, we also can consider it an autoimmune dysfunction where the body attacks and it makes, it destroys the beta cells in the body. The beta cells are responsible for producing insulin in the islet of Langerhans located in the pancreas. What happens is that the immune system cells and the antibodies are going to be present in the circulation. And it can also be triggered by certain genetic tissues or even viral infections. Type 2 diabetes is a progressive condition caused by the inability of our body cells to respond to the insulin. We also call this insulin resistance. And it can also be due to a decreased production of insulin by those beta cells. So it's either an inability of the cells to respond, insulin resistance, or a decreased production of insulin by the beta cells. Type 2 diabetes is linked to obesity, that sedentary lifestyle, and it can also be hereditary. And that metabolic syndrome often precedes type 2 diabetes. So remember that metabolic syndrome that we talked about just a few slides back. That is going to be your, where is it? That is your patient that has that abdominal fat that's considered overweight or obese, the patient that has hypertension. They're going to have that elevated lipid and triglycerides. They're going to have high blood glucose levels, and they're going to have that sedentary lifestyle. We do see that diabetes is significantly more prevalent in African American, American Indians, and the Hispanic population, and it is also more common in men than women. So when we're doing diabetic screenings on our patients, we need to look at some of their risk factors. So are they obese? If you're in the primary care setting and you're seeing these patients on a regular basis, you will be able to compare and contrast their weight from previous visits. You're going to be monitoring their blood pressure, determining if they have hypertension, and you also want to talk to them about their lifestyle. So what do they do for exercise? Do they work in a field where they're on their feet all the time and they're constantly moving, or are they sitting behind a desk and they don't like to exercise? You're going to want to be doing labs to look at their lipid levels to determine if they have high cholesterol, which we call hyperlipidemia. Cigarette smoking, we want to ask them if they smoke now or if they have smoked in the past, and if so, how many packs and how long ago they quit. We also want to know their genetic history. So does anyone in their family suffer from diabetes, type 1 or type 2? We said that it is more prevalent in certain ethnic populations, so we want to look to see what population they fall into. And then women who also have polycystic ovary syndrome or who have delivered infants that weigh more than 9 pounds at birth are also at a risk for developing diabetes. So we would want to ask them if they see a gynecologist, and if they do, when was their last visit, and has it ever been determined that they had this polycystic ovary syndrome? And if they've had children, then we would want to inquire as to how much they weighed when they were born and how many weeks they were when they delivered. The American Diabetes Association does recommend screening a client who has a BMI of greater than 25 and age greater than 45 years old, or if the child at the visit that you're screening them for is determined to be overweight. We would also want to do a screening with fasting glucose serum levels, and we would want to look at that that A1C level that would determine how well their blood glucose was managed over that period of 2 to 3 months. So these are just some of the, this is a cute little chart to help you guys to determine the signs and symptoms of type 1 diabetes. So for type 1, we're going to have the 3 Ps: polyuria, polydipsia, and polyphagia. So polyuria is increased urination, polydipsia is increased thirst, polyphagia is increased hunger. These patients are going to present with weight loss. They're going to complain of fatigue. They might even complain of an increased frequency of infections, UTIs, skin infections. Usually with type 1 diabetes, it is a very rapid onset. It's not gradual like our type 2 diabetes patients. And these patients will be insulin dependent because their body does not make any insulin. We do see that familial tendency, so this is usually hereditary in families. And then we see a peak incidence from 10 to 15 years. All right, so a little patho and etiology. So type 1 diabetes, also known as juvenile diabetes, because it is usually diagnosed when children are younger. It doesn't mean that you can't be older, but we do see the bigger part of these patients being diagnosed when they are children. They make no insulin at all, so there is no insulin production. So we see that whole breakdown in the body, like I spoke about, the lipolysis. So the body's going to burn fat and protein. We're going to see the ketones build up in the body, which is going to lead to that ketoacidosis. It's also considered an autoimmune disorder, and the signs and symptoms are going to be very rapid. With our type 2, we're going to have the insulin resistance or the insufficient insulin can also be inherited. Obesity is usually the trigger. It's going to lead to an excess level of glucose in the blood. That excess glucose in the blood is going to lead to glycosuria. It's going to cause glucose in the urine, and it's going to be excreted in our urine. Glycosuria usually appears when our patient's blood glucose levels get above 180. The kidney's renal threshold, remember that is the ability of the kidneys to be able to reabsorb glucose and return it to the bloodstream. That whole process is going to be impaired because there's too much glucose in the blood at that point, and it's very viscous. So the kidneys just can't handle it. The concentration of glucose is very hypertonic. So we know what happens with our hypertonic solutions. It's going to pull fluid into our vascular system. Once our circulating volume increases, it's going to result in that polyuria. So they're going to have that excessive urine production. They're going to be going to the bathroom very frequently to urinate. They're going to have an increased amount of urine excreted. Because they have so much water that's lost, they're going to have that polydipsia, which is that excess thirst. They're at a higher risk for infection. The increase for the demand of insulin on the body can cause stress because the pancreas cannot accommodate the demand. It's going to lead to an increased risk of vascular disorders. These patients can develop atherosclerosis. They can have cerebral vascular accidents, so strokes. They're at risk for myocardial infarction, which is a heart attack. They definitely are at risk for that peripheral vascular disease. Once they have that disease, they're going to develop those ulcers on the legs, and they're not going to be able to heal. Eventually, we're going to see renal failure. They can lose their sight, and they can develop neuropathy. We're going to talk a lot more about these a little bit later on. And then we said the signs and symptoms have a more gradual onset, where the diabetes type 1 is very rapid onset. All right, so let's talk a little bit about hyperglycemia. So hyper, we know hyper is anything that's increased. Glycemia, we're talking about glucose. So hyperglycemia is increased glucose levels. So for our patients, our signs and symptoms. So we're talking about blood glucose levels greater than 250. Again, this is just kind of like a rule of thumb. It's what your book talks about in your clinical settings wherever you work. You're going to want to follow your policies and procedures, whatever they determine is considered hyperglycemia wherever you work. So it's a blood glucose level greater than 250. We're going to see the 3 Ps. So we have that polyuria, which is that excess urine production, and frequent osmotic diuresis. Remember, because we said that hypertonic, the glucose creates that hypertonic medium. It's going to keep pulling fluid into the vascular space, and it's going to increase our urine production. Because we're pulling so much fluid in, we are going to be dehydrated. So now we're going to be thirsty. So we have polydipsia, excessive thirst due to dehydration. These patients are dehydrated, so they're going to have a loss of skin turgor. Their skin is going to be warm and dry. Their mucous membranes are going to be dry. They may complain of weakness or malaise. And remember, if our circulating volume is going to be low, we're going to have a rapid, weak pulse and hypotension because all of that fluid is being pulled into the cells. These patients also have polyphagia, so excessive hunger and eating caused by an inability of the cells to be able to receive glucose. They can't receive glucose because there's a lack of insulin, or we have that insulin resistance. And then we also said that the body's using protein and fat for energy. So they're in that state of ketosis. So these patients may present with weight loss. Those ketones are going to accumulate in the blood because we're breaking down the fatty acids because the insulin is not available. These patients will present with what we call Kussmaul's respiration. So these are an increase in your respiratory rate and their depth. So you're going to see a work of breathing in these patients because they are attempting to excrete the carbon dioxide and the acid because they are suffering with metabolic acidosis. So Kussmaul's respirations because of the ketones that are in the blood. So this is just another slide to show you what you might see with hyperglycemia: drowsiness, frequent urination, maybe some nausea, extreme thirst, extreme hunger, blurred vision, and they're going to have dry skin, warm and dry skin. So some other assessment findings that we might see these patients have kind of a fruity breath odor. So this is caused from the acetone. It's when these ketones accumulate in the body, these patients kind of get a fruity odor to their breath. Not all patients, but some patients will. They can present with a headache, nausea, vomiting, maybe some abdominal pain. They'll have an increased inability to be able to concentrate, fatigue, weakness. They're going to complain of vision changes. Blurred vision usually is what they complain of. If they have wounds anywhere, they're going to be very slow to heal. Too much glucose in the system won't allow your wounds to heal. They may have a decreased level of consciousness, and if left untreated, they can develop seizures, which could lead to a coma. Some patients also are at risk for developing those skin infections that I talked about a couple of slides back. So skin infections, urinary tract infections, and for women, those vaginal infections, because when we have elevated levels of blood glucose, it supports bacterial growth. So it's very common to see these infections. That blurred vision that we talked about, we see because of the hypertonicity of the blood fluid. It's going to affect our cells in our lenses and our retina. So some laboratory tests that we're going to want to do a fasting blood glucose. So if our patient has that, we are going to want to instruct them to fast. So no food or drink other than water for about a period of 8 hours prior to the blood test. If they have to do what's called an oral glucose tolerance test, that's also a fasting blood glucose level, which we draw at the very beginning of the test. After we draw that, we give them a special drink to consume. It includes a specified amount of glucose. After they drink that, we obtain those blood glucose levels again every 30 minutes for 2 hours to see how their blood responds. It is very important that during the process of this test, we assess these patients for the development of hypoglycemia to make sure that that doesn't develop. So we will talk also about the symptoms of hypoglycemia so you guys know what to look at. We can also look at a glycosylated hemoglobin, that's that A1C. This is going to be our best indicator of the average blood glucose level for the past 120 days. It is very useful in evaluating treatment effectiveness and compliance. So if you have a patient in the primary care setting that's been diagnosed with diabetes and they're starting on medication, and we're instructing them to take the medication and we're educating them about changing their diet, when they come back in 3 months and we do this A1C, we would expect that the number has decreased. So say they were above normal the first time, maybe they were around a 7. If they have been compliant with their medication and with their diet, that number would decrease. So if patients come in and say, oh yeah, I've been compliant, I've been eating this, I've been eating that, I've been taking my medicine, well, the test will definitely tell us if they're telling the truth. So it's a very useful test. So you guys can go into your book, page 926, table 51.2, take a look at the diagnostic tests for detecting glucose intolerance. We can also encourage our patients to monitor their own blood glucose levels at home. This is extremely important. We want to make sure that they know how to use the machines, they know how to use the everything that goes with it, and that they know the proper times to test their blood sugar. Depending on how far their diabetes has gone, what their numbers are, is going to determine how often they have to monitor their blood glucose. But a lot of people monitor their blood glucose levels at home that have diabetes. And then we could supply short-term short-acting insulin to patients that have elevated pre-meal glucose levels. We're going to talk a lot more in detail about different medications and insulins that we can give. So you guys can look at page 927 in your book. It's going to give you an example of a blood glucose monitor that uses blood sampled from a finger stick. You guys should know that. All right, so for patients that require medication, so depending on what their blood glucose levels are, they don't always have to go on insulin or an oral hyperglycemic. So sometimes they just need the oral hyperglycemic if they're at a mid-range. If their blood glucose is high all the time, we know it can be dangerous, so they may have to go on insulin. Or sometimes they're just at that pre-diabetes, and it can be reversed with management of their diet and exercise. So it just depends. So if our patients do require medications, one of the medications that we can give is insulin. So mainly your patients who have type 1 diabetes, this is what they have to take. Oral hyperglycemics don't really work for them. So the insulin is usually given 1 or more times a day based on their blood glucose levels. Every patient is different, and every treatment option is specialized just for that patient. So usually what we give is a dosage, it's called U100 insulin, and what that U100 means is that for every 1 ml of insulin in the container, it is going to contain 100 units of insulin. And we're going to talk more about the insulin delivery systems too. So insulin can be required by some type 2 diabetes or gestational diabetes, which is when pregnant women develop diabetes. If the glycemic control cannot be obtained with diet, exercise, and those oral hypoglycemic agents. Insulin pens that we usually use, you're going to see them in another 2 slides. These insulin pens are pre-filled cartridges. These cartridges contain between 150 to 300 units of insulin per pen. It's in a programmable device, and it has disposable needles that go on the end of it. You can also have a continuous infusion of insulin, which can be given to the patient via a pump that they wear externally, usually on their abdomen, sometimes on the back of the arm. And then, of course, we have oral hypoglycemics are going to be used by patients who have type 2 diabetes. And when they take this, it's usually in conjunction with diet and exercise. We don't just give it to them and say, here, take this, it's going to lower your blood sugar. We need to see the medication, the diet, and the exercise to really get a good handle on those elevated blood glucose levels. So this is an example of what an insulin pump would look like. So the insulin that's going to be delivered to the patient is going to be inside of that pump. It's a little cartridge. Inside the cartridge, it has a reservoir. That's where the insulin is going to be. This other piece over here is going to go into the abdomen. So the needle is going to be in place in their abdominal region by what they call an infusion set. And a little adhesive patch that's going to be stuck to the skin. So there is a fine needle that goes in there. And then the insulin is going to travel into the body through a flexible tube that ends with that tiny needle, which is called the cannula, that again is inserted under the skin. All right, so for our insulin, so up in the right-hand corner is our insulin pen. And that is the pen that contains between 150 to 300 units of insulin. So insulin is always given in units, and it's usually given by what we call a sliding scale. And what we mean by a sliding scale is that we will, in your computer system, when a patient comes in and they're ordered insulin, the doctor puts in an order set for this sliding scale. And what the scale says is it gives a range of numbers. So it might say if you have a blood glucose level of 140 or less, you don't require any insulin. If you have a blood glucose level of 140 to maybe 200, you would get 1 unit. So it's a scale that gives a variety of different numbers and tells you how much insulin to give to your patients. That's what we call a sliding scale. let me see real quick if I can just bring up for you guys what a sliding scale looks like. If you've been in clinical, you have probably seen this in the computer if you've given meds, but I just want everybody to understand what, okay. So this is perfect. This is what you usually see, wait a minute, in your computer. Okay, so actually we don't usually have 3 comments. This is usually what it looks like. So this would be in your MAR. So if they had a blood glucose level of 61 to 150, they wouldn't give any insulin. If their blood glucose was 150 to 200, they might get 3. And if their blood glucose was 201 to 250, they would get 5. So that's what a sliding scale looks like. And it can be different for each patient depending on what type, if they're on a low dose insulin, a medium dose, or a high dose insulin. But that is what we call sliding scale. Okay, so the different type of insulins that we have. So we have rapid acting insulin, short acting insulin, intermediate acting insulin, and long acting insulin. So our rapid acting insulin, the types that we usually see in the clinical setting, we have insulin Lispro, we have insulin Aspart, which is also Novolog, which is what that pen is in the upper right-hand corner. That's usually what most hospitals have. And then we have something called Apidra, which is a newer type of insulin. So when we talk about our rapid acting insulin, the onset of this insulin is going to occur rapidly. So once we give it, it's going to work quickly, usually within 10 to 13 minutes. This can be administered in conjunction with intermediate or long acting to help control glycemic between meals and at night. So sometimes people will eat a meal and their blood glucose will go up, so they might need something that works a little bit longer. So we know things that work rapidly don't stay in the system long, kind of like with our IV medications. Well, insulin is very similar to that. So it works quickly, but it's not going to give you that all-day coverage. So because it works rapidly, we usually give this 3 times a day: breakfast, lunch, and dinner. And this can be given 3 times a day with blood glucose levels. So when the patients are in the hospital, the nurse or the tech is going to go in before breakfast, before lunch, and before dinner, and they're going to check that blood glucose level. And then they would administer sliding scale coverage based upon that blood glucose level. Whether the patient was eating or not is usually how the order goes in. I don't mean if the patient is NPO, I mean that the patient has a diet ordered, but even if they're not eating breakfast that morning, if they say, I'm just not hungry, we're still going to give the coverage if the glucose is elevated, because the insulin is ordered for the glucose, for the elevated blood glucose. We want to be able to control the elevated blood sugars. You may also see that they order something called a meal dose. So for every meal, breakfast, lunch, and dinner, they may have 2 orders for insulin. One is just going to be for the blood glucose level, whether they choose to eat or not, because we want to control the blood glucose. The second dose is going to be ordered to be given with meals. So it's basically, these are patients who have increased spikes in their blood sugar when they eat. So we're giving insulin to cover their meals, what they eat, to keep it in a controlled level so it doesn't skyrocket. Now that is a different exception to giving the insulin. If the patient decides they're not going to eat, we would not give that mealtime dose because they're not eating, and it would be too much insulin in their body and it would drop their sugar too low. So if they have a mealtime dose and they're not eating, you guys would not want to give that dose, okay? We can also give a short-acting insulin, which is regular insulin. This is going to be administered 30 to 60 minutes before meals to control that postprandial hyperglycemia. So postprandial means after meals. Usually, this is going to be a U500, which you would never give U500 insulin through an IV. Usually, if any patient's getting IV insulin, they're going to be in the intensive care unit. We can't give that on regular med-surg floors. U100, I believe, is given through the IV. I've never given IV insulin, so I'm not exactly sure. Intermediate acting insulin, so this is administered to help glycemic control between meals and at night. So it's going to last a little bit longer. Subcutaneous only, and it can be mixed with that short acting insulin. Then we have our long-acting insulin. This is our insulin glargine or our insulin Devamere. This is for people who really struggle with being able to control their blood sugar throughout the day. Also at night as well. Sometimes they get this before they go to bed, but they also can get it during the day. It's usually administered once daily, anytime during the day, but always at the same time of each day. This is only delivered subcutaneously, and it's never given IV. You should go to page 929 in your book, read table 51.3. It talks, 51-3, it talks about insulin and the analog preparations. That would be good for you guys to know. One thing to think about when we're giving our patients insulin is that we need to make sure that we are always rotating their sites. So if you're a daytime nurse, you're going to be giving insulin to your patient 3 times a day, probably breakfast, lunch, and dinner. So you should always ask them during the breakfast dose, where did they have their dose of insulin administered last night? And if they remember, then you want to do the opposite side. It's important that we really rotate those injection sites because we want to avoid the patient from developing lipoatrophy. So lipoatrophy is when their subcutaneous fats at the site of those where we put those injections starts to break down. They can also develop lipohypertrophy, which is a buildup of the subcutaneous fat at the site of those repeated injections. What's going to happen is that if they develop either one of those, it's going to be able to interfere with the body's ability to absorb the insulin, and we're not going to get good blood glucose coverage. So this was from your book. This just shows some of the ideal places to give insulin. So I've never given insulin in the back above the butt cheeks like that. I've never, you can, but I've never given it there. So usually when patients come in the hospital, it's hard for them to do the back of their arm. So when they do it to themselves at home, they're always doing their belly. So they like to have a break when they come in the hospital, and they'll ask for you to do it on the back of their arm because it just gives their belly a break. So definitely on the belly, 1 to 2 inches around the umbilicus is the best place because that's where it's better absorbed. If they really don't want it there, then we can do the back of the arms right here, and we could also do the thighs, but we really, really like to educate that we like to do around the umbilicus because that's where it's best absorbed. So for medical management, it's going to depend on the type of diabetes that they have. Obviously, we want to encourage diet and weight loss. These are major, major components of treatment. We don't want these patients to be dependent on insulin and oral hyperglycemics for the rest of their life. So if they have type 2 diabetes, we want to encourage diet and weight loss management. We can teach our patients to count grams of carbohydrates consumed because that ultimately is going to give them that great glycemic control that we're looking for. So we can do something called the diabetic exchange. So the diabetic exchange is a list. You can get it on the internet. It's a list of common foods and the list that was created to make carb counting easier for patients that have diabetes. So a serving size of one starchy food contains 15 grams of carbs. So if you go to this list and you look under white rice, it may say a half of a cup. That serving is the equivalent of 15 grams of carbohydrates. So they call it one carbohydrate exchange. So they can look on that list and anything that they see on there, it'll automatically give them the serving size, which is the equivalent of those 15 grams or one carbohydrate exchange. So we talked about the insulin, the types of insulin that we can give. So what it's made of, we can have human insulin, we can have beef insulin and pork insulin. We also want to teach our patients the appropriate techniques for self-monitoring of blood glucose. So we want to make sure if they come in the hospital when they're just diagnosed, we want to do a lot of education with them. We want them to practice with, usually we give them a machine and the supplies they need to go home. We want to practice with them, make sure that they understand the times of the day that they are going to be drawing their blood sugar. Again, it depends on what their levels look like and how severe their diabetes is. Depends on what their ritual is going to look like at home. So we want to make sure that they understand what they're monitoring for. We want to make sure that they understand how to use the equipment, that they know how to do a blood sample. It would be great to sit with the patients before they leave and have them test their blood sugar so that you know when they go home that they know how to use the machine. We want to encourage them to record their results so that when they go back to their primary care physician, they can show them what their blood glucose levels have looked like. And we also want them to understand what their levels mean. So if they have a blood glucose level between 70 and 100, we want them to understand that that means that they probably won't require any insulin at that particular time. If they have levels greater than 150, they might need one insulin. So, 1 unit of insulin. So we really need to make sure that they understand what their sliding scale requires and that they need to be able to understand their glucose readings and be able to respond accordingly. And then as far as giving the insulin, we want to make sure that they know how to administer their insulin. So we want to be able to watch them in the hospital before they go home, practice with their pen and administer them, some insulin for them. If they are unable to do it for some reason, if they have a family member at home that's going to be doing it for them, we want to make sure that the family members know how to do it as well. We want to make sure that they have all the information they need regarding the self-administration of insulin, make sure that things are written down, give them as much education as possible, and then definitely teach about rotating those sites because we want to prevent that lipohypertrophy or that lipoatrophy with the subcutaneous tissue. So some patients will take oral anti-diabetic agents. This is our type 2 diabetes patients that will be taking these. There are certain requirements to be able to take the oral hyperglycemics versus the having to take the insulin. So usually it is for patients that have fasting blood glucose levels less than 200, or their insulin requirement is less than 40 units per day. They cannot have any ketoacidosis or any renal or hepatic disease. So that would be the criteria for being able to take the oral medication. We have a couple different kinds. We have sulfonylureas, we have biguanides, we have alpha glucosidase inhibitors. The sulfonylureas, one of the main medications in that category is glipizide. Glipizide works by stimulating the insulin release from the pancreas, and it's obviously going to cause a decrease in blood glucose levels. Our biguanides, one of their medications that we see used all the time is metformin. Metformin works to reduce the blood glucose production of glucose by the liver. These patients that take metformin, they experience some pretty uncomfortable GI effects. So they complain of a lot of flatulence, anorexia, loss of appetite, and then nausea and vomiting. So those are some things to educate your patients about and watch for. The alpha glucosidase inhibitors, we see miglatol or acarbose. These work by causing slow carbohydrate absorption from the intestinal tract, which reduces that post-meal hyperglycemia that we see after patients eat. Some patients will require a pancreas transplantation. So this patient that gets this is usually a type 1 diabetic who has renal failure and will usually benefit from a kidney transplant and a pancreas transplant. Then we can also see that some patients get what's called an islet cell transplantation. So this is after the organ, the pancreas, is harvested from the patient that is donating it. The islet cells are then separated from the tissue, and they take them and they inject them through the abdominal wall into the client's portal vein. They start to migrate to the liver and they begin to release insulin. You can read figure 51-11 on page 937, and then also the nursing care plan 51-1 on page 938. Okay, so diabetic ketoacidosis is an acute, life-threatening condition that's going to be characterized by uncontrolled hyperglycemia, usually greater than 300. It's going to result in the breakdown of that body fat for energy. The patient's going to be dehydrated. They're going to have metabolic acidosis, and they're going to have an accumulation of those ketones in their blood and their urine. So patients that develop diabetic ketoacidosis, these will be our patients who are non-compliant with treatment. They eat whatever they want. They don't take their oral pills. They don't take their insulin. It can also be caused by a sudden development of an infection, causes stress on the body and exacerbates the diabetes. So they develop diabetic ketoacidosis, or we can also see it in our brittle diabetics or unstable diabetics. So these patients are very hard to manage. It's not that they're not compliant or that they're not taking the medication. It's that their diabetes are considered brittle and they're unstable. So it's just really hard for whatever reason to keep their levels where they need to be. So they are also at risk for developing DKA. So these patients, it is metabolic acidosis. They are in an acidotic state. They are at a high risk for this situation to develop into a coma. That onset of DKA is usually very rapid, and it does have a mortality rate of up to 10%. So risk factors, again, any condition that increases carbohydrate metabolism, so physical or emotional stress, an illness, an infection, usually an infection is the #1 cause, a recent surgery or some type of trauma that requires an increased need for insulin. So signs and symptoms of DKA, polyuria, polydipsia, dehydration, so they're going to have tachycardia and orthostasis, so that orthostatic hypertension, the low blood circulating volume, they're dehydrated. So their heart rate is going to be elevated because their body is working harder to increase the flow of blood throughout the body. Abdominal pain, nausea, vomiting, they might have that fruity breath because of the acetone. They're going to have that Kussmaul's breathing, and they might see mental status changes. So they could be combative, they could be acting like they're drunk, or they could appear to be in a coma. So expected findings: weakness, thirst, anorexia, vomiting, drowsiness, blurred vision, headache, abdominal pain, Kussmaul's respirations, orthostatic hypotension because of that low circulating blood volume, metabolic acidosis, mental status changes, seizures, and sometimes they develop paralysis, but it is going to be reversible. So laboratory tests that we're going to see, obviously, we're going to see those serum glucose levels greater than 300. We're also going to look at our kidney labs. So our BUN, which is our blood urea nitrogen, those levels are going to be greater than 30. Our creatinine levels are going to be greater than 1.5. And the osmolarity is going to be high. Remember, all of our kidney levels are going to be elevated because we have so much glucose in our blood that it's well beyond our renal threshold. The kidneys just can't handle all the glucose, so they're working in overtime. So all of those levels are going to be increased. If we look for ketones in the serum and in our urine, they're going to be present. We might do an ABG. It's going to show metabolic acidosis with respiratory compensation, right? Because we're going to have those two small respirations. We're going to increase our respirations in our rate and our depth because we're trying to blow off the carbon dioxide. So metabolic acidosis with respiratory compensation. And then we would see a pH of less than 7.3. So our main goals to manage DKA is we need to reduce that elevated blood glucose levels. We have to correct the fluid and electrolyte imbalances, and we want to clear the urine and blood of all of those ketones so that the kidneys can work more efficiently and they're not overloaded by all that glucose. So these patients will probably be admitted to the ICU. They're going to be given IV insulin. So they're probably going to get a bolus, which is that quick infusion of insulin, and we're going to follow it with a continuous infusion until those numbers come down. The amount of insulin and the rate of the infusion obviously is going to depend on those blood glucose levels. We also will give insulin, but then we will give a continuous infusion of some type of fluid with some glucose in it because we don't want to cause cerebral edema. We want to provide rapid isotonic fluid, 0.9 sodium chloride replacement to maintain perfusion to all of our vital organs. As our insulin begins to lower the blood glucose level, the IV solution is changed to one with glucose, a small amount of glucose. We're going to give potassium replacements. We're going to monitor our patient for hypokalemia. So you guys would want to go back to your homeostasis slides and freshen up on what these signs and symptoms of hypokalemia would be. And we are going to really concentrate on replacing those intracellular storage of our K. And we might have to administer sodium bicarb for severe acidosis. So some nursing diagnosis that we might see: deficient fluid volume related to excess excretion of urine, nausea, vomiting, and increased respirations; impaired memory related to fluid and electrolyte imbalance; imbalanced nutrition; less than body requirements related to body's inability to use nutrients; risk for unstable blood glucose levels, risk factor, deficient knowledge of diabetes management; risk for powerlessness, risk factor, illness-related regimen; risk for impaired resilience, risk factor, complications of disease. So these patients can also develop something called HHS. So hyperosmolar, hyperglycemic, non-ketotic syndrome, HHNS. Oops, I'm missing the N. Sorry, guys. All right, so this is an acute complication of diabetes. It is hyperglycemia, so elevated blood glucose levels without that ketosis. So they don't have that ketotic state that we were talking about with the DKA. These blood glucose levels will be well over 500. That's not out of the norm to see levels that high. The pH of the blood is going to remain within normal range. So there's no metabolic acidosis with these patients, and we don't have the elevated levels of ketones. But they will have fluid and electrolyte imbalances. So this is usually an onset, generally is going to occur gradually over several days. However, if patients do not recognize the symptoms and they leave it untreated, it can lead to coma and then actually to death. Excuse me, it results from some type of serious illness in the body, maybe an infection, and it can also come from diuresis. There is a lack of sufficient insulin related to undiagnosed diabetes mellitus. Being undiagnosed is going to lead to high blood glucose levels, so hyperglycemia, which is that hyperglycemia, remember we said, is going to cause fluid to move from the intracellular to the extracellular area. Once that happens, diuresis is going to occur, and we're going to see a loss of sodium and potassium. This client is still secreting some insulin, and it can take some glucose into the cells. So because we see some of that still happening, we're not seeing the fat metabolism that's really having an effect on the body. And if it is happening, it's very minimal. This is why we don't have that ketosis developing in the patients, because there is still some insulin. Inadequate fluid intake or poor kidney function can also contribute to the development of HHNS. So we want to monitor strict isonos on these patients, and we want to be looking at their kidney function. So assessment findings, hypotension. So we might see with that dehydration, that low circulating volume, we might see mental changes, extreme thirst. They're going to be dehydrated. We're going to see a low circulating blood volume, so they're going to have tachycardia because the heart is pumping faster to increase our circulating volume. Remember, the fluid is moving from the ICF into the ECF, so you guys might need to go back to your first set of slides in homeostasis and remember where your fluid sits. In the cell, the ICF, the ECF, make sure you have a good understanding of what is where, and then you will understand these processes that we're talking about. Some patients may present with a fever, possible neurologic signs. We may see some paralysis, lethargy, coma, and seizures. We're going to see symptoms of hypokalemia and I can't stop yawning. Hypokalemia and hyponatremia. Physical examination, we're going to see that poor skin turgor and dry mucous membranes. These patients are dehydrated. Diagnostic findings, we're going to look at those serum glucose levels. We would expect them to be greater than 500. We're going to be looking at our BUN and our creatinine. So our BUN elevated, greater than 300, creatinine greater than 1.5. Osmolarity also increased, greater than 1.5. Our ABGs, we're looking at our serum pH, going to be greater than 7.4. Serum electrolytes, we're going to see low potassium and low sodium. So, nursing diagnosis, acute confusion related to dehydration and electrolyte imbalance, deficient fluid volume related to polyuria, hyperglycemia, inadequate fluid intake, risk for electrolyte imbalance, risk factor, effect of metabolic state on kidney function, risk for injury, seizures, risk factors, hyperosmolar state, and electrolyte imbalance. So these patients obviously are going to get insulin administration, probably IV at first, so they would be in the ICU. We're going to make sure we're doing correction of the fluid and electrolyte imbalances, and they may need a central catheter, which they would put in the ICU, and that's going to be used to monitor the client's hemodynamic response to the fluid replacement that we are giving. So this just is a nice little scale that gives you kind of like the differences between DKA and HHS. All right, so hypoglycemia. So hypoglycemia, hypo, low glycemia, blood sugar, blood glucose. So this is low blood sugar. So we know that hypoglycemia is always a potential for our patients to develop when we give them insulin or some type of oral hyperglycemic. So You know, just like with our fluid replacement, patients become dehydrated, we give them fluid. It's always this balancing act. It's always possible to give them too much. Well, insulin is the same thing, just like our blood pressure. If our patients have high blood pressure, we give them blood pressure medicine. We know that we're always monitoring them because we know they're at risk for developing low blood pressure now. So blood sugar is the same thing. So you have a patient that has elevated blood glucose, we give them insulin. We need to monitor these patients for the development of hypoglycemia. So it is caused by hyperinsulinism. So we give them too much insulin. We would see blood glucose levels less than 60. Your book talks about blood glucose levels less than 60. In my facility, it's less than 70. So ultimately, wherever you work, you're just going to follow your facility's policies. We see the development of hypoglycemia in patients that have diabetes that don't eat at all, but continue to take insulin or anti-diabetic medications. We see it occur if they are not eating sufficient calories to compensate for their glucose-lowering medications. We see it with patients who exercise more than usual because it lowers the available glucose that we have. And we see it with patients who consume alcohol because alcohol interferes with the liver's ability to synthesize glucose from non-carbohydrates. So when we have a patient who is not eating at all and they continue to take insulin, we know that we can drop their blood sugar. So if you have a patient in the hospital, when this happens very frequently, so you guys really have to be aware of this. If you have a patient that comes in and they're not eating, say that they have an NPO diet, but they are a diabetic, we would never give them an order to administer insulin AC and HS. AC and HS, remember, is with meals and before bedtime. So patients that are NPO should always be on Q6. So we want to look at their blood sugar every 6 hours, and we give a different type of insulin. We don't use the Novolog, we use the regular insulin for these patients that are NPO. So that's the first thing you guys need to recognize. So if you come in and you see that the doctor orders AC and HS finger sticks and sliding scale for your patient who is NPO, you're going to want to call the doctor and make sure that they switch that order to Q6 because we don't want to lower their blood sugar. And then with exercise. So what exercise does is exercise helps the way our bodies metabolize our carbs, and it is an effective way of controlling our blood glucose levels. So in our skeletal muscles, we have certain glucose transporting receptors that allow our muscles to take in glucose from our blood, independent from our insulin. It only happens when we exercise. So this, now that you guys know that, it should make sense to you why hypoglycemia occurs when patients exercise, because you have that extra mechanism there for lowering the blood glucose, and it's going to give our patients energy, and it shows you if they exercise and monitor their diet, how they can be successful with lowering their blood sugar. And we know that a delay in food absorption can also cause hypoglycemia. So if patients that have like gastroparesis, things like that, things that cause the patient to have issues with with absorbing their food, it can cause their blood glucose levels to drop. So that's why we say with these patients that have elevated blood sugar and they have mealtime dose, we don't give them their insulin until their meals come, because we don't want to drop their blood sugar without any food. So signs and symptoms of hypoglycemia. So because glucose is our primary source of energy, especially when it comes to the brain, we tend to see neurologic changes in our patients first. So if we have a patient that starts to deteriorate and they lose consciousness, or they just all of a sudden are confused and they start saying things that don't make sense, you know, that is one of the first things we do. We get a blood glucose because we want to find out if they have hypoglycemia, because it is usually one of the first things that we see. They can be confused. They can just stop talking altogether, and they can seem like they're in a coma. They can also be very tachycardic. They can be weak. They can have a headache. They can get nervous. They can complain of nausea, extreme fatigue, very, very hungry, malaise. They might be excessively perspiring, so sweating, confused, coordination difficulty. They might fall down. They might complain of double vision. They might have personality or behavioral changes. And if left untreated, unconsciousness can ultimately occur, and they can have seizures. Okay, so some of the things that we might see with hypoglycemia, you can use this: tired, so tachycardia, irritable, restless, excessive hunger, diaphoresis, depression, but really confusion too. I want you guys to think about that. Again, shaking, sweating, anxious, dizzy, hunger, fast heartbeat, impaired vision, weakness, fatigue, headache, irritable. So diagnostic findings, obviously we are going to check our patient's blood glucose levels with the glucometer, and then we will treat them accordingly. So we want to make sure that the client is eating a meal within 15 minutes of administering rapid-acting insulin and within 30 minutes of giving short-acting insulin. So with that being said, this is what your book talks about. In my own practice, I don't give it until the meal's there, because in the hospital setting, anything can happen, especially with meal delivery. So the patient may say, Trish, I ordered my meal 45 minutes ago. They said it would be here in 45 minutes. I do not give that insulin until that food is in their room directly in front of them and the client is ready to eat. Because what happens if I give that insulin thinking that the tray will be up in 15 minutes or any minute and it's late, or they lose the tray and the patient doesn't eat? Well, now we've given them insulin, especially a meal dose insulin. We've given that based upon the fact that they were eating a meal and they're not, and their blood glucose levels will drop and they will get hypoglycemia. So in your own practice, that is something that I recommend you do to really keep the patient safe. Hypoglycemia is a preventative measures to avoid excess insulin. So remember, we talked about exercise. So we want to, when the doctors are talking, the endocrinologists or the doctors are planning for their insulin management at home, if they exercise, that is something that we really need to know, because we know that what exercise does for blood glucose. So we're going to want to think about that when we are preparing their insulin regimen. And then talking to patients about alcohol consumption on an empty stomach. If we're in a hospital and our patients, we check their blood sugar and it's less than 60 or 70, whatever your policy is, the first thing we want to do is we want to think we got to bring that blood sugar up. So if your patient is conscious and can swallow and eat, we want to administer 15 to 20 grams of some type of simple carbohydrate, usually 4 teaspoons to 6 ounces of fruit juices or regular soda. We can give them 6 to 10 hard candies, or we could even give them a tablespoon of honey. So in the hospital setting, we don't have hard candies or honey, so we usually go give them an orange juice, and I usually add a couple sugar packets to it because I want to make sure that it comes up pretty rapidly. And then you want to recheck that blood glucose in 15 minutes to make sure that the blood glucose has come back up. In the hospital, like I said, we usually just do the orange juice. If the patient is unconscious or they have some issue where they're not able to swallow, we want to give them glucagon subcutaneously or IM. We want to place the patient into a lateral position because we want to prevent aspiration. So if they cannot, if they're NPO, or if they have some issue where they just can't swallow, maybe they've had a stroke, or if they're completely unconscious, obviously they can't take anything by mouth because they're not awake. So you would have to do the glucagon. So usually what happens when you come into the hospital is that if a patient is a diabetic and they have orders for insulin, they also have this order set. It's a whole order set. So it tells you when you're doing your finger sticks, when to administer the insulin, what times of the day, with meals or without. And it's also going to give you medication, this glucagon, or 50% dextrose, to give in case the blood sugar drops. It's already sitting there, PRN, in case you need it. If you see orders come through for your patient and you know they're a diabetic and they don't have that, you would want to reach out to your doctor sooner rather than later and make sure that that medication is there for you in case you need it. Sometimes these patients need an IV administration of 50% dextrose. Consciousness should usually occur within 20 minutes. It doesn't usually take that long in my experience with my patients. They usually come around within 5 to 10 minutes usually after I give them that medicine IV. So some nursing diagnosis, we have acute confusion related to insufficient blood glucose to the brain, ineffective health management related to deficient knowledge regarding disease process and self-care, imbalanced nutrition, less than body requirements related to imbalance of glucose and insulin level, risk for unstable blood glucose levels. So we did talk earlier in our slides and said that patients that have diabetes are at a high risk for developing chronic health complications because of the diabetes. So some of the ones that we're going to talk about are peripheral neuropathy, diabetic neuropathy, diabetic retinopathy, and vascular disturbances. So peripheral neuropathy is a very, very, very common thing that we see with patients. And this is the main reason when I'm doing my physical assessment on patients, one of the questions I ask them is, do you have any numbness or tingling in your hands or feet? So peripheral neuropathy is caused from damage to the sensory nerve fibers in our body in our patients that have diabetes, and it causes numbness and tingling or pain, or a combination of all three. It is a very progressive disease, and it can affect every aspect of the body, and it can eventually lead to ischemia and an increased risk of infection. So our pathophysiology and etiology is going to be obviously that poor blood glucose control, which causes decreased blood circulation to the nerve tissue. Because remember, the blood is so thick, it doesn't perfuse our body like it's supposed to. So we have that decreased blood circulation to our nerve tissue. It is a very gradual onset. Because it develops so gradually, usually the patient is unaware. We can have motor neuropathy. So this is where the nerves are affected. The muscles weaken and they also atrophy. Their joints are the support in their joints is very diminished. And we actually see that their feet widen and we see the development of skeletal deformities. Their skin and their soft tissue are also going to be subjected to friction and pressure, and it is over time going to cause the development of ulcers. These ulcers, they might not even feel because their nerve endings are, remember we have that decreased blood circulation to the nerve endings, so they develop ulcers on their feet, which they can't see. Because they're not good at looking at their feet, or they're overweight and they can't always see the bottom of their feet, or they just don't look and they get these ulcers on their feet and they can just develop into infections and they don't know why. And then they come to the hospital and people look, someone looks at their foot and they're like, oh, you have this huge sore on your foot. So, and then obviously if there is an infection or impaired healing, portions of the affected extremity may require amputation. So patients that have diabetes are at a high risk of losing fingers, toes, usually their feet, so their toes, their entire feet, sometimes above the knee or below the knee. This is very common for poorly controlled blood glucose levels in diabetics over a period of time. They can develop sensory neuropathy. So this is neuropathy that's involving the sensory nerves, leads to paresthesias. So those abnormal sensations they might describe as prickling, tickling, burning, needle-like pain in the feet, the legs, sometimes the hands. Sometimes the feeling is totally lost. The lack of sensitivity increases the potential for soft tissue injury without the client's awareness. So these are those ulcers and those sores on the feet. We can have autonomic neuropathy. So this is neuropathy of the autonomic nerves. So these patients will develop gastroparesis. So their stomach motility is going to be impaired because they don't have, they have neuropathy of those autonomic nerves, and they won't be able to propel the food through the stomach. So that delays the absorption of their food. Their bladder nerves can also be compromised, so the client will not have the sense to urge to urinate. The retained urine is going to support a medium for bacteria to grow, and then these patients are going to develop urinary tract infections. Some patients will also develop erectile dysfunction, and then we're going to see cardiovascular issues that can cause episodes of orthostatic hypotension to occur. So what are our assessment findings, our signs and symptoms? We may see pain, swollen feet. The patient's skeletal muscles in their extremities are going to become smaller because they're losing muscle. The feet swell and they become insensitive to temperature or other tactile stimulation. All right, so we want to administer non-narcotic analgesics to help the patient with their pain. You want to give anticonvulsants such as Lyrica, gabapentin, also known as Neurontin, Tegretol. These provide pain relief for the nerve pain. So it's going to help with the pain in their legs, the numbness, the tingling that they feel. That's all comes from nerve pain. So anticonvulsants, we give these obviously to control seizures, but these are also medications that work to control nerve pain. We want to give them elastic compression stockings to help get that blood flow back to the heart. We don't want to have any blood clots. We can give midodrine, which will help reduce the orthostatic hypotension that we're going to see because of these cardiovascular issues that diabetes causes. We can give Reglan, which is going to help relieve the symptoms associated with gastroparesis. It's going to help increase the motility in the stomach and move that food along. And then we would want to also encourage these patients to eat small, frequent meals to help with the gastroparesis. So we're going to want to monitor the blood glucose levels and make sure that we are keeping them within acceptable ranges to help slow the progression. We want to stress the importance of proper foot care to our patients. So we want to encourage them that they should be going to see a podiatrist every so often for nail care. So they want to go and have their feet examined, and they want to have them clip their nails, trim them, so they don't develop any ingrown toenails or develop any sores. We want to encourage the patients or their family members to help them inspect their feet daily. Make sure you're looking for any areas that are red for the development of any ulcers. Our patients should be washing their feet daily with mild soap and warm water. Monitoring the temperature of the water is extremely important because remember we said with some of these patients, they don't have a great feeling in their feet. So they also, if they don't know that they have a sore, they also can't tell if the water's too hot and they could burn their skin. And we want to encourage them to wear clean, absorbent socks to help protect their feet. The other thing with these patients is if they are in the hospital and they have this numbness and tingling, they're probably at a risk for high falls, right? Because if they have numbness and tingling in their feet, that is going to put them at risk for having a fall if they can't feel and walk properly. So something to think about for your inpatient patients and keeping them safe. And then we want to encourage them to rise slowly from lying or in the sitting position. We want them to drink generous fluids and to wear knee-high or thigh-high elastic stockings during waking hours. Diabetic nephropathy is damage to the kidneys from prolonged elevated blood levels and dehydration. This develops because the glomeruli become deteriorated. When they become deteriorated, it results in impaired filtration of our blood during the urine formation. There are 5 stages of diabetic nephropathy. The final stage is end-stage kidney disease. These patients in that stage and in stage 4 usually end up on dialysis. Assessment findings, we're going to see swollen feet and hands, gradual increases in their blood pressure. They may be tired, they may feel weak. Their BUN, their serum creatinine are all going to become elevated. Their renal creatinine clearance is going to be decreased. And their urinalysis, if we drew one, would show that they have albumin in their urine. So for medical management, what we want to do is we want to help control that blood glucose. We want to give insulin and or those oral hyperglycemics. We want to control their hypertensive, so tension. So we want to administer antihypertensives if they have them ordered. We want to make sure they're on a low salt diet. And then we want to have a moderate reduction in their dietary protein. Remember, we talked about the albumin levels. And then smoking cessation is going to be strongly recommended. So nursing management, we want to monitor hydration and kidney function, strict I's and O's, their serum creatinine, report hourly output less than 30 mLs per hour because we know our kidneys are not functioning if we're not putting out at least 30 mLs per hour. Monitor those blood pressures, control the blood pressures and glucose levels, encourage yearly urinalysis, BUN, microalbumin levels, serum creatinine, encourage the client to avoid soda, alcohol, and toxic levels of acetaminophen or NSAIDs. Teach the client to consume 2 to 3 liters of fluids per day from food and beverages with artificial sweetener and to drink adequate amounts of water. And tell the client to report a decrease in output at home to their provider. Then we have diabetic retinopathy. So this is impaired vision or blindness. This occurs as a result of these increased blood glucose levels. It causes vascular changes in the retina, which changes the vision. There are 2 types. We have non-proliferative and proliferative blindness. Assessment findings for these patients, they are going to report diminished visual acuity. We are going to probably send them for an ophthalmology exam to see what type of changes has occurred since their last visit, or it could be a first visit if they've never had one before. We could do a fluorescein angiography, which gives us a picture of the retina. And then nursing and medical management. We want to encourage our patients to have yearly eye exams because we want them to keep their, protect their vision and keep up the health of their eyes. We want to encourage the management of blood glucose levels so that we can ultimately prevent this from happening. And we also said that we could develop vascular disturbances. So we can develop thickening of the arterial walls. The patients can develop CAD, which is coronary artery disease. And they can also experience hyperlipidemia. So these patients are going to have cool extremities. They might experience leg cramps. They might develop gangrene from ulcers or untreated wounds. They might have skin ulcers, myocardial infarction, so heart attacks. So diagnostic findings, so we might do Doppler studies of their extremities to see how the blood flow is. We could do a CT angiogram to see how the blood flow moves through the heart. We're going to want to rule out PE, pulmonary embolisms, and blood clots. We will be looking at Troponins, if we think they're having a myocardial infarction, so we would be looking at those 3 sets of troponins over 8 hours each. We could look at CKMB, which would also explain if they had, which would show a breakdown of skeletal muscle, which we sometimes see in our patients who have heart attacks. And then nursing medical management, we would administer lipid-lowering agents, vasodilators, platelet aggregation reduction drugs so that they don't have blood clots. So Plavix, heparin, Lovenox, things like that. And that is it. That is your PowerPoint presentation for diabetes. If you guys have any questions, you can send me an email and I will answer any questions that you have.